Okay, so good morning, everyone. I'm today going to talk about the management of the upper tract urothelial cancer. It's quite a big topic, so I'm going to tailor my presentation. I'm going to expand on some parts, and I'm going to skip on some parts of the overall management of urothelial cancer. Okay, so objectives are going to touch briefly on epidemiology, some molecular genetics, an overview of the disease management. I'm going to talk about different techniques of managing the lower end, quickly touch on the role of lymph node dissection. I'm going to try to expand or spend more time on the role of chemotherapy, because this is where the new papers are, and I guess that a lot of the previous stuff you might heard of already. So broadly speaking about upper tract TCC, it's a rare disease, and this is the difficulty in doing clinical trials in upper tract urothelial cancer. The incidence roughly is about 2 per 100,000 population per year. The male to female ratio is 2 to 1 in upper tract, which is different to the bladder, which is 4 to 1 in bladder cancer. It's uncommon and only accounts for 5 to 10% of all urothelial cancers. If we compare stage for stage, upper tract has got poorer prognosis than urothelial cancers of the urinary bladder. Pelvic or pyelocalyceal tumors are more common than urethral tumors, and they're probably twice as more common as urethral tumors. The disease tends to be multifocal in 10 to 20% of the cases, and presence of CIS, concomitant CIS in the upper tract is between 11 to 35%. Equally, there is about 17% of cases who have concurrent bladder cancer at the same time. Recurrence in the bladder is quite common and occurs in between 20 to 50% of the time. Hence, bladder surveillance is recommended after treating. 2 to 6% have got a disease in the contralateral upper tract. And unlike bladder cancer, this one, 56% have got a locally advanced disease at presentation. Also, 50% of the patients who have been diagnosed with upper tract urothelial cancer, they die as a result of their disease despite treatment. So quickly touching on the basics of genetics for upper tract urothelial cancer in general first. So there is a bit of difference between low-grade and high-grade cancers. With low-grade urothelial cancers, commonly there is an FGFR3 mutation that leads to activation of the RAS-MAPK pathway that causes cell proliferation, but usually it's a non-lethal cancer. While in high-grade CIS and T1 disease, it's more loss of the P53 or RB, which are tumor suppressor genes, that leads to genetic instability, which causes disease progression and potentially a lethal cancer. There is this study from MSK, which looked at the difference between upper tract urothelial cancer and the bladder cancer. They had 195 patients with upper tract urothelial cancer and nearly 450 of bladder cancers. And the patients were on the MSK Impact platform. And the broad lines from this, the most frequently mutated genes were FGFR in upper tract urothelial cancer, were FGFR3 in 40% overall, KMT2D roughly about 40% again, KDMA 6A 32%, P53 26%, and Aridia 23%. In higher stage disease, there was more alterations in the P53 and the MDM2, which was clinically significant. And there were fewer alterations in the RTK/RAS pathway. In terms of the frequency of activating alterations in FGFR3 and HRAS, they were lower in patients with higher stage disease. And the numbers, as you can see, and they were statistically significant. Also, conversely, the frequency of alterations in P53 and MDM2 were significantly increased in patients with higher stage disease, and the numbers are, as you can see, the difference. What is the difference between upper tract urothelial cancer and bladder cancer? If we're gonna, this is quite good and quite simplistic for my brain, and this is an overall. So with upper tract urothelial cancer, it's more HRAS and FGFR3, while bladder cancer generally RB1, P53, and ERB2. And probably this is, if you want to take a home for our residents, and this probably is the take-home slide if you want to take about genetics. If you go for more, slight more detail, non-muscle invasive urothelial cancer, the FGFR3, there was more common in upper tract, but that was not statistically significant. While the statistically significant ones, which more common, HRAS 17% to 20%, and KMT 30% compared to 12% in bladder cancer. And if we look at the muscle invasive urothelial cancer, in muscle invasive urothelial cancer,
you guys, please, everybody mute your line. I hear people speaking in the background.
in muscle invasive, P53 and RB1 were more common in bladder cancer, in muscle invasive bladder cancer or higher, and HRAS was more common in, alterations were more common in upper tract urothelial muscle invasive urothelial cancer. If we talk about risk factors, it's similar but not exactly typical to bladder cancer. Smoking, that's similar. There is the aristolochic acid, which causes bulk nephropathy, and it's also present in some Chinese herbs that has been contributed or attributed to causing urothelial cancer. Lynch syndrome, there is lots we can give a whole lecture about the correlations between bladder and urothelial cancer and Lynch syndrome. There is some occupational exposure, phenacetine, and some talks about arsenic acid exposure, which causes Blackfoot disease, which was more common in Taiwan. Next slide is about the risk stratification of upper tract urothelial cancer. We don't use that term very commonly in upper tract urothelial cancer. We use it a lot in prostate, perhaps bladder and kidney, but this is from the EAU guidelines. They classify upper tract urothelial cancer into low risk and high risk based on these criteria. For low risk, it has to be unifocal disease, tumor size less than 2 centimeters, low-grade cytology, low-grade biopsy, and non-invasive on imaging. While high risk, presence of hydronephrosis classifies that as a high risk, tumor size more than 2 centimeters, high-grade cytology, high-grade biopsy, multifocal disease, and previous radical cystectomy for high-grade bladder cancer, and also presence of variant histology on the biopsy. Talking about disease management, generally speaking, the gold standard is nephrouretrectomy plus excision of bladder cuff. Some people say plus or minus a lymphadenectomy, but this is debatable. We were going to talk about that. Overall, we should consider kidney sparing if you've got a solitary kidney, if you've got a low-risk cancer, even if the contralateral kidney is normal. And also in distal tumors, you can consider kidney sparing even if it's a high grade. And we will show the evidence about that. What are the techniques for kidney preservation? You try uretroscopy and endoscopic ablation. You need to have complete clearance, which sometimes is difficult. And normally bear in mind that there will be high recurrence rate. You will use laser coagulation, as you can see here, and different types of laser have been used, or you can coagulate. Also, percutaneous access and resection for tumors in the renal pelvis mainly. Bear in mind that catchbacks are risk of tumor seeding, and it's mainly guided at low-grade tumors that are inaccessible with uretroscopy, which is a rare situation these days. Other techniques of preserving the kidney is you perform a segmental resection or upper tract installations of topical agents. So moving into segmental resection. Segmental resection with wide margins normally will give you adequate pathological specimens for staging and accurate grading while preserving the ipsilateral kidney. If you want, you can do the lymphadenectomy as well at the same time during the segmental resection. And usually segmental resection of the proximal 2/3 of the ureter is associated with higher risks of failure compared to the distal ureter. So it's more commonly used in distal ureter tumors, because it's also easier to reconstruct the urinary tract for the distal tumors. Looking at some evidence for segmental uretrectomy, this paper by Hong et al., they had 112 patients, 77 had nephew and 35 had segmental resection. They followed up the patients for 4 years approximately. And on the right here, you can see the Kaplan-Meier graph for the bladder recurrence-free survival. And you can see that the green line is the segmental uretrectomy and the blue line is radical nephrouretrectomy. And there is no really difference between the two in terms of bladder cancer-free survival. If we look at this one, this is looking at the local recurrence-free survival. And actually, the segmental uretrectomy line is higher than the radical nephrectomy line in blue, but the difference was not statistically significant. And in terms of cancer-specific survival, same. There is no statistical significant difference between segmental uretrectomy and radical nephew. They concluded that segmental uretrectomy is not inferior to radical nephew for urethral cancers in terms of oncological outcomes, and it's less invasive and has better nephron sparing preservation compared with radical nephew. This is a bigger study, which is a review article or systematic review from the European Urology, looking at different oncological outcomes of kidney sparing techniques. So as I said, this was a systematic review. They included nearly almost 600 segmental uretrectomy cases and more than 3,500 radical nephew cases. In terms of cancer-specific survival, there was no significant difference at 3 years and at 5 years. And in terms of overall survival, in terms of metastasis recurrence-free survival, local recurrence-free survival, and bladder recurrence-free survival, the estimates were similar. The rates of requiring a salvage nephew range between only 4 to 7%. So it wasn't that high. The mean time to procedure was roughly between 3 to 4 years. And in conclusion, they are saying that indications for segmental uretrectomy could be extended to selected cases of high risk upper tract urothelial cancer while maintaining good oncological outcomes or similar. Moving into upper tract installation of topical agents, and the idea is you either put BCG or mitomycin in the urinary tract, whether that is antegrade or via nephrostomy, or retrograde via a ureteric catheter, after you have done a complete tumor ablation or eradication. What's the evidence for that? This is a paper from Dr. Studer's group in Switzerland, published in the European Urology. It's mainly addressing the use of BCG. So that was a prospective study. They had 55 patients with 64 renal units treated. All had upper non-muscle invasive upper tract urothelial cancer. It was mainly antegrade BCG perfusion of the upper tract, either with curative intent for CIS or as an adjuvant treatment after you've ablated or endoscopically eradicated TA and T1 tumors. 42 patients with CIS and 22 with TA and T1 tumors. Median follow-up was 42 months. In terms of recurrence, overall recurrence was 47%. That was 40% with CIS and 59%, almost 60% with TA and T1 tumors. In terms of the progression, overall 17%. That happened in 5% of CIS and 41% with TA and T1 tumors. In terms of requirement to perform a nephew, 5% for CIS, and almost 25% in TA and T1 tumors. Overall, there was a high kidney preservation rate, but it seems that CIS was benefited more than TA and T1 tumors with upper tract BCG. This is another study by Metcalf, I think from MD Anderson. Because BCG has shown inferior outcomes for upper tract urothelial cancer compared to bladder cancer, they did a retrospective study including 27 patients with 28 renal units. They were treated endoscopically and then received mitomycin C, not BCG here. This was delivered either retrograde via a ureteric catheter or via a percutaneous nephrostomy. Retrograde was more common, 70% compared to 30% of patients had nephrostomies. Low grade, 21 patients, and high grade, only 7 patients. The regimen included 6 weekly induction instillations, then monthly installation of mitomycin. When we look at the 3-year recurrence-free survival, roughly 60% for low grade and high grade. In terms of progression-free survival, 80% for the low grade and 67% for the high grade. In terms of the 3-year nephroureterectomy free, overall 76%, so they saved a lot of kidneys, and that was 82% for the low grade and 67% for the high grade. Overall cancer-specific mortality was 0, and overall survival was 92.9%. I think part of that is the majority of the patients were low grade. There is another review article published in the Urological Oncology by Forrester et al. And in this review article, there was 438 patients identified, and 18 studies were included for quantitative analysis. The adjuvant installation, which is basically after you treat endoscopically, TA and T1 patients, 40% recurrence rate, 94% clinical cancer-specific survival, and 71% overall survival. I think these figures are probably more realistic because the study cohort is bigger. The installation approach doesn't show any difference, so whether you do that percutaneously or retrograde doesn't matter. Patients with upper tract CIS treated with BCG, the pooled estimate for cytology response was 84%, recurrence 34%, progression 16%. For TA and T1 disease, the recurrence rates were comparable to that reported in the literature for non-treated patients. So it makes you wonder about the value of giving installations for TA and T1 disease. It's probably good for BCG, for CIS, but for upper tract, it's a bit questionable. I have to say, we deliver these treatments here. We've got a couple of patients that we deliver these treatments between me and Thomas in the office here. One is a BCG via percutaneous nephrostomy for CIS, and the other guy is a low-grade urothelial cancer, I think TA, via a ureteric catheter. The logistics are very difficult, and while it sounds nice in theory, but the reason this is not very popular, each treatment takes about an hour and a half to 2 hours. There is lots of technical and practical aspects, like a small air bubble in the tubing, or the patient moves. It's difficult for him to stay for an hour and a half not moving, and every small movement will alter the change of the infusion. The feasibility of getting X-ray to confirm position of the ureteric catheter, and that is done once a week for 6 consecutive weeks. So it's a lot of logistics things to think about if you want to consider giving these treatments. Moving on to the management of high-risk non-metastatic upper tract urothelial cancer. So classically, open radical nephroureterectomy with bladder cuff excision is the standard treatment, regardless of the tumor location. You can consider minimally invasive radical nephew. However, the few papers, mainly European papers, are not very enthusiastic about minimally invasive surgery for nephew. They are commenting about case reports of retroperitoneal metastatic dissemination and metastasis along the trocar pathway. The precautions they recommend to avoid the risk of tumor spillage is basics of urothelial cancer: avoid entering the urinary tract, avoid contact between your instruments and the tumor, do the procedure in a closed system, avoid morcellation of the tumor. This is historic, nobody does that now. Most importantly is remove the kidney and the ureter en bloc with the bladder cuff. They're also saying for T3 and T4 disease, whether there is lymph nodes or not, don't do minimally invasive surgery, not because you can do it, you technically can, but the outcomes are, the oncological outcomes are not as good compared to open approach, as per that paper published in the European Urology Focus. Management of the bladder cuff. I don't think the surgeons in the room will ever agree on how they're going to do the lower end, and there is no level 1 evidence, and everyone will do probably what he feels comfortable with. There are endoscopic techniques, including the plug technique, where you basically use a Collins knife circumferentially incise around the ureteric orifice and go deep into the fat, and then when you do your laparoscopic, you pluck it from the top. Stripping or resecting the ureter and the intramural ureter, and this one is kind of oncologically not really safe and not following the principles of managing upper tract urothelial cancer. Some people do interception of the ureter and they pull it out urethrally, but they will have to transect the ureter, so that's entering the urinary tract, tying a knot around the ureter with a ureteric catheter and pull it out urethrally. So none of these techniques have conventionally been shown to be equal to complete bladder cuff excision. In terms of complete excision, whether that you do the extravesical, transvesical, open, laparoscopic, or more commonly, or robotic nowadays with the XI robot, which doesn't need redocking, and you can do an extravesical excision of the bladder cuff. And I'm sure me and Dr. Black will refer to closing the bladder laparoscopically down, deep down in the pelvis. It's a bit challenging, and it's probably more pleasant to do it robotically. In terms of the distal ureter and the bladder cuff management, there is no question here about the oncological importance of a formal bladder cuff excision. The recurrence rate in the distal urethral stump is between 30 to 65%. So whatever way you do it, just make sure you take the stump and completely, because going in to dig a urethral stump recurrent is a surgical nightmare usually, and you might end up losing the bladder with it. There is no level 1 evidence exists to support one strategy over another, and surgeon's preference and comfort level is the deciding factor usually. So I've talked a lot about European studies. Now I'm going to talk about a Canadian study, which is probably the largest about managing the distal ureter. In this Canadian study, there was 820 patients done over 20 years from 10 tertiary centers across Canada. 50% of patients were done intravesical, nearly 40% extravesical, and 12% where the bladder cuff was managed endoscopically. If we look at the recurrence-free survival rates at 5 years, you can see here that there was 46 recurrence-free for intravesical, so that's the least bladder recurrence, or recurrence-free least recurrence. 35% extra with the extravesical approach, and 30% with endoscopic approach. So the Canadian series is probably more is favoring intravesical. The other paper, which is going back to a European paper in the European Urology, this was a retrospective analysis of more than 2,500 patients treated with nephew for upper tract urothelial cancers from 24 international institutions. The transvesical approach was used in 67%, extravesical 30%, and endoscopic only 3%. There was no difference in terms of the recurrence-free survival, cancer-specific survival, and overall survival. However, endoscopic approach had a significantly higher risk of intravesical recurrence. There was no difference between intravesical and extravesical, and the approaches in that retrospective analysis. Recurrence-free survival estimates at 2 and 5 years for transvesical 70 and 58%, extravesical again 70 and 51%, endoscopic 61 and 42%. What are the risk factors for intravesical recurrence? There are factors related to the patient, which is male gender, previous bladder cancer, and preoperative CKD. There are tumor factors, which are positive preoperative urinary cytology, urethral location, multifocality, invasive T-stage, and necrosis. There is treatment-specific factors, which are laparoscopic approach, extravesical bladder cuff removal, and positive surgical margins. And actually, interestingly, previous diagnostic ureteroscopy has been contributed as a risk factor for intravesical recurrence. This is probably another very debatable topic, which is the role of the lymphadenectomy. We're talking about the use of a lymph node template is likely to have a greater impact on patient survival than compared to the number of removed lymph nodes. So it's more the template rather than the number of lymph nodes you remove. And this paper by Kondo et al. Showing a 3-year overall survival of 86% for the template group versus 48% for the non-template group. Another factor is template-based and completeness of the lymph node dissection improves cancer-specific survival in patients with muscle-invasive disease and reduces the risk of local recurrence. Also, lymphadenectomy, even in clinically and pathologically node-negative patients, improves survival as per this paper by Dong et al. The lymph node dissection appears to be unnecessary in case of TA and T1 disease because of the low risk of lymph node metastasis in these cases, and this has been shown on different and multiple studies. But there is an interesting statement from the EAU which contradicts the previous statement, which is because of the tumor staging is inaccurate preoperatively, they recommend a template-based lymph node dissection to all patients who are planned for a NFU. And I know that this is quite debatable. What are the templates? The templates from this paper by Kondo et al. In the right, so it depends on the location of the tumor in the ureter. So if you're talking about renal pelvic tumors, on the right side is hilar lymph nodes, precaval and retrocaval. On the left hilar and para-aortic. If you move on to tumors of the upper 2/3, the template will include the right hilar, precaval, retrocaval, but in addition the interaortocaval, and on the left side, left hilar and the para-aortic. For the tumors of the lower third, they are very similar to a very extended lymph node dissection of bladder cancer. So basically the common area, external, internal, and obturator lymph nodes on the side of the tumor. Moving now to chemotherapy in upper tract urothelial cancer. First, there is the role of intravesical chemotherapy after you do an FU. So there is only 2 randomized trials in this field. One of them is a British study by Tim O'Brien from Guy's and St Thomas Hospital in London, published in the European Urology. They looked at 46 British centers between 2000 and 2006, 280 patients going for NFU. They randomized patients between a single post-operative dose of mitomycin C versus standard management, roughly 140 patients in each arm. They performed bladder surveillance at 3, 6, and 12 months with a flexible cystoscopy. The results from in terms of bladder cancer recurrence, in the mitomycin arm 17%, and in the no mitomycin arm 27%. And the graph here shows statistically significant difference between giving a single dose of post-operative mitomycin versus no mitomycin. The relative risk reduction was 40%, and the number needed to treat to prevent one bladder cancer recurrence was 9. The timing, the catch, maybe the timing of the giving the mitomycin, it was basically at the time of the catheter removal, which was variable between surgeons. Usually it was between 7 to 10 days, but there was some outliers, some people 2 weeks and some people slightly less. The other trial in terms of intravesical chemotherapy was a Japanese trial published in the Journal of Clinical Oncology. It only had 77 patients from 11 institutions over 3-4 years. They were randomly assigned to intravesical pyrarubicin, 48 hours of NFU versus no intravesical chemo. The median follow-up was 25 months in the treatment group and 14 months in the control group. The recurrence rate at 1 year was 17% for the treatment versus 32% for the control, and at 2 years, 17% for treatment and 42% for control. So they are showing that there is benefit of giving intravesical chemotherapy, particularly in this case, pyrarubicin. That was for intravesical chemotherapy after NFU. Now moving on to role of neoadjuvant chemo. We all know that there is level 1 evidence supporting cisplatin-based neoadjuvant chemo in muscle-invasive bladder cancer, showing an absolute improvement in 5% in overall survival at 5 years, but there is very limited data in upper tract urothelial cancer. Many patients are ineligible for adjuvant platinum-based chemo after radical NFU because of renal insufficiency. The rationale is treatment of the micrometastasis and ability to administer a full dose of cisplatin chemo before you remove the renal unit, compared to adjuvant when you've already removed one kidney with the expected effect on overall renal function. The challenges of obtaining a definitive histology and accurate staging for upper tract urothelial cancer before you do the nephrectomy risk either you undertreat or overtreat, and this is mainly a concern in the medical oncology community. What are the papers to support neoadjuvant chemo? Not many, but this review by Lo et al. They included 5 neoadjuvant chemotherapy studies. All were retrospective. There was 2 multi-center and 3 were single center. Sample size was small and probably maybe 40 odd patients was the highest number in each study. There was 2 phase 2 trials that showed favorable pathological downstaging, and 2 retrospective studies investigating neoadjuvant chemo shows disease-specific survival. But again, they are retrospective, single center, so it's not a strong level of evidence to support it. A more recent study published just 5 weeks ago in the Journal of Urology, and this is a phase 2 trial of neoadjuvant systemic chemotherapy, followed by radical NFU with high-grade upper tract urothelial cancer by Margolis et al. It's a multi-institution American study. High-grade non-metastatic upper tract urothelial cancer, that was all patients. The creatinine clearance had to be more than 30 ml per minute, good ejection fraction more than 50%, and no grade 2 or higher neuropathy. So these were the selection criteria for the patients. They gave the patients with creatinine clearance more than 50, they gave them accelerated MVAC protocol, and they recruited, the intention was 30 patients in each arm, but they recruited 29 patients in this arm. For patients with creatinine clearance between 30 to 50%, they gave gem carbo, but they actually recruited only 6 patients in this arm. So the numbers are not that great. All patients went for radical NFU plus lymph node dissection, and the primary endpoint was pathological complete response, not survival, whether overall or cancer specific. So the results from the paper shows that the pathological complete response was 14%. So that's 14% of patients will have a T0 disease. If you think about bladder cancer, that is probably in the range of 30%. That was in the MVAC arm, and 62% had T1 or less disease. So they concluded the MVAC was safe and well tolerated, but in the gem carbo carbo arm only recruited 6 patients, so maybe you can't really make much of that. Also, another publication from this year, which is the POUT trial. This here is talking about adjuvant chemotherapy. I think the study design and the numbers are a bit better in this trial. It's published in The Lancet in March 2020. So POUT stands for perioperative chemotherapy versus surveillance in upper tract urothelial cancer. It was a phase 3 open label randomized controlled trial at 71 hospitals across the UK. Upper tract urothelial cancer after NEFU stage as either T2 or T4. So you had accurate staging of and you can properly select high grade or high risk cancers. Pathology any N, either N0 to N3, but no METs, or any T stage plus positive lymph nodes and no METs. They were randomized 1-to-1 to either surveillance or 4 21-day cycles of chemotherapy. The chemotherapy initiated within 90 days of the NEFU. The chemotherapy was cisplatin or carboplatin if the GFR was less than 50, plus gemcitabine. The primary endpoint was disease-free survival analyzed by the intention to treat. And the secondary endpoints were metastasis-free survival, overall survival, treatment compliance, acute toxicity, late toxicity, and patient-reported quality of life. There was 261 participants in the study over 5 years, 132 randomized to chemotherapy and 129 for surveillance. Median age was 68. If post-operative imaging was mandated before randomization, and those who had residual lymph node disease radiologically evident, they were excluded. The participant had satisfactory blood work and a GFR of 30 ml per minute or higher. So clearly the ones between 30 to 50 were assigned for gem and carbo, not cisplatin. The follow-up, the patients were followed up at 3, 6, 9, and 12 months, then every 6 months for 3 years. The radiological follow-up was composed of chest X-ray or CT of the thorax plus CT of the abdomen and pelvis at 3, 6, at 9 months it was only the chest, then 12, 18, 20, basically every 6 months with occasional only chest imaging, and then annually up to 5 years. They did cystoscopy every 6 months for 2 years, then once per year up to 5 years. So the big question is, why did they do this trial and why did they design it as an adjuvant chemo, not neoadjuvant? Again, it was the challenges of obtaining a definitive histology and accurate staging before the NEFU, and there was risk of either under-treating or over-treating with neoadjuvant chemo. Therefore, they designed the trial for adjuvant chemotherapy. We don't have to forget that chemotherapy can be quite toxic and can give a lot of side effects, and there might be some mortality from the chemotherapy from neutropenic sepsis and other things. So you need to really give it to the patients who really need it. The results from the POUT, there were fewer disease-related events contributing to the primary endpoint were reported in the participants allocated chemotherapy. So that was 27%, versus 47% for patients allocated surveillance. Chemotherapy conferred 55% reduction in the relative risk of disease recurrence or death, and that was statistically significant. The 3-year disease-free survival estimates were 71% in patients allocated chemotherapy and 46% for those allocated surveillance. So that concluded an estimated absolute difference of 25%. The median disease-free survival among patients allocated surveillance was roughly 30 months. It's not mentioned for the chemotherapy group. Participants allocated chemotherapy had a lower risk of metastasis or death. The 3-year event-free rates was 71% among patients allocated chemotherapy, 53% in patients allocated surveillance, with an estimated absolute difference of 17%. grade 3 or worse acute treatment emergent adverse events were reported for 44% of participants who started chemotherapy, compared with 4% of those managed with surveillance. And that was statistically significant, but you can understand that these patients will have chemotherapy, they will have some side effects. This is the graph. The red line is the chemotherapy. The blue line is the surveillance arm. And you can see that the chemotherapy arm is well separated in terms of disease-free survival from the beginning over till the end of the observation period. Metastasis-free survival, same case. The chemotherapy line is well separated from the blue line, which is the surveillance arm, and these are clinically significant, statistically significant. When we looked at the subgroup analysis of those patients, gemcitabine cisplatin seems to be more beneficial than gem-carbo. We probably know that. The margin status, patients with positive margin benefited, but the ones with negative margins benefited more. The more advanced disease had more benefit than the T2 disease, but both groups had benefit by having chemotherapy. They also looked at the quality of life of patients who underwent both arms. So the red line, as usual, is the chemotherapy. Blue line is the surveillance. You can see here in the beginning of the treatment, in the first few months when the patients are having chemotherapy, the quality of life is less. And the patients on surveillance have got better quality of life. But a year down the line, they're pretty much equal. There is no difference in terms of quality of life a year later. So in conclusion of the POUT trial, gemcitabine and platinum-based chemotherapy initiated within 90 days after NEFU significantly improved disease-free survival in patients with locally advanced upper tract urothelial cancer. The adjuvant platinum-based chemotherapy should be considered as a new standard of care after NEFU for this patient population. So what is missing in the POUT trial? We're still waiting on overall survival data, and they're planning to publish that later once they had 88 deaths or all participants had at least 2 years of follow-up, and they have not achieved that yet. And also the mature quality of life data, they are planning to do full quality of life data analysis once everyone had 2 years of follow-up as well. In terms of, so these trials are basically based on just the standard or classical chemotherapy. We are going into the era now of more checkpoint inhibitors, FGFR inhibitors. So I guess that the future trials will probably look at including these treatments in the either adjuvant or neoadjuvant context. So for FGFR inhibitors like erdafitinib, we either giving it alone or with combination of the chemotherapy regimens, and we might be molecularly selecting patients who will benefit from FGFR inhibitors. And in terms of checkpoint inhibitors, either given alone or again with combination of cytotoxic chemotherapy, and the combinations probably used in urothelial cancer is pembro and atezolizumab are the ones to look out for. So this is for future trial designs. Thank you.